So is it full now?
Yes, perfect.
So the outline of my presentation will be, I will discuss the incidence. So mostly I will be discussing incidence in India and recent changes in ICROP classification, which was there was some changes in 2021. So I will be discussing about that. A brief slide on pathophysiology, not much, and then the primary prevention part and screening and treatment part. So, coming to the introduction first. So, as we all know that one of ROP is one of the leading causes of severe visual impairment in childhood, and you know that if we fail screening of the patient with ROP, the baby will be blind for life. So, it is very important for us to know about the pathophysiology and how to prevent ROP. So coming to the incidence part, so this is an slide on AIMS data, which was from 2013 to 2019. So, so in AIMS, what we do is we do screening in only less than 32 weeks or less than 1500 gram babies. So there the protocol is like that only. So in that data, what we found was that any ROP was 36%. Type 1 ROP, that means requiring laser or anti-VEGF therapy, was 8.8%, and type 2 ROP, that doesn't require any treatment, was 3.3%. And the median time for detection of ROP was 6 weeks, 6 weeks post-menstrual age. And type 1 ROP is 9 weeks. So usually, if we get a baby of around 26 weeks, so the baby will be getting ROP around 32 weeks. So any ROP, and the ROP requiring treatment will be around 35 to 36 weeks. So there was another study from PGI where they compared the incidence between different weight and gestational age. The incidence was compared in the era of 1993 and now again in 2013 to 14. So in less than 1,000 gram babies, the incidence was 89.5% at that time, and now it has reduced to 44.4%. And from 1,000 to 1,500 gram babies, the incidence was 54%, which has reduced to 28.5. And for more than 1,500, it was 26.4%, which has reduced to 7.4%. And similarly, for gestational age between less than 28 weeks, which was around 91.62, it has reduced to 57. And you can see that there was 5% babies more than equal to 34 weeks, which were having ROP. So this was the reason why RBSK guidelines are telling us to do ROP screening in more than equal to 34 weeks. And this was the data from PGI. So the other SNCUs, like where the quality of care and oxygen use is rampant, so this incidence might be more. So that is why our RBSK and NNF guidelines are saying that do screen babies more than equal to 34 weeks if they have any risk factors, which we'll be discussing further slides. So other important update which has come in ICROP guidelines, I will be discussing on that. So how to classify ROP? So you all know that we classify according to the zone, stage, and whether any plus disease is there, or and the ophthalmologists also write the extent in the form of clock hours, how much extent of retina is involved. So this is how classification of ROP is done. So in the recent, not able to change the slide. Yes. So everybody must be aware about this figure. So zone is divided in zone 1, 2, and 3. So zone 1 is a circle whose radius is twice the distance from the center of the optic disc. So this is the optic disc, and this is macula. So the distance of the circle is, the radius is twice the distance between this distance between the center of the optic disc to the center of the macula. So a circle is drawn. So this is zone 1, and zone 2 is whose circle is the distance from the center of the optic disc to the nasal margin of the retina. So here a circle is found, and this whole region is zone 2. And recently they have ICROP has uh, given the importance to posterior zone 2, because you can see that it is very close to the macula. So any ROP in this posterior zone 2 region is very dangerous. So they have demarcated that, and it is a circle which is peripheral to the zone 1, and it is around the area of the 2 disc diameters. इसके 2 diameter के distance जितना इन्होंने एक और circle बना दिया, and which is known as posterior zone 2. So this is the major change which has occurred in the ICROP 2021 guidelines. So posterior zone 2 has been demarcated, and zone 3 is the crescent shaped area which remained beyond the zone 2, this whole area. So remainder of the retina from zone 2 to the ora serrata on the nasal side and equator on the temporal. Then they have also given a new term which is known as, notch. So notch is the incursion of the avascular retina. So you can see that this is a vascular retina, and this is the avascular retina, this white portion. So this is the incursion of ROP lesion of around 1 to 2 clock hours into the posterior zone 2 area. So if so this notch lesions are very common in late preterm babies. So they have demarcated and given this new definition, notch, in the new ICROP guidelines. Then severity staging, everybody must be knowing that. So stage 1 is demarcation line, stage 2 is demarcation ridge. So you get the height and width. Then the stage 3 is extra retina fibrovascular proliferation, and 4A is partial retinal detachment with the fovea attached, and 4B is fovea detached, and complete retinal detachment 5A, B, C. So in 5A, the optic disc is visible by ophthalmoscopy. So it is an open funnel detachment. 5B is optic disc is not visible because of retrolental fibrovascular tissue. So there is a posterior opacity. So your optic disc is not visible. It is known as closed funnel detachment. And 5B, 5C, 5B the anterior segment changes. So anterior segment changes भी अगर आ जाएं तो 5C हो जाता है. And so any baby reaching this 4 and 5 stage is the prognosis of visual is very bad. Vision is very bad. So we should avoid that catching these babies in this stage. So you should catch these babies in the earlier stages 1, 2, 3, where the visual prognosis is relatively good. So plus disease is always mentioned in the ROP reports. So in plus disease, what is done is that there is increased venous dilatation. So you can see that this venous dilatation is there, and there is tortuosity of the arterioles. So you can see this tortuosity, and there is pure pupillary dilatation. So the pupil is rigid. So whenever you put dilatory drops and the pupil is still not dilating, so you should suspect plus disease. Then you must be aware of the term AP-ROP, aggressive posterior ROP. So this term has been changed to aggressive ROP. So now it is known as AROP. So it is defined as rapidly progressive severe form of ROP, and mostly found in smallest and most immature infants. So aggressive ROP में होता क्या है अभी, there is no sequence of changes. जैसे दूसरा ROP stage 1 में जाएगा, 2 में जाएगा, 3 में जाएगा, but in this AROP what happens is there is no sequence of changes. From stage 1 to 2, the baby will go directly into stage 4. So very dangerous disease, very rapidly progressive, and there is you can see there is arterial tortuosity, and there is exudative exudates also. So this bold portions is exudative. So it is basically exudative retinopathy, and it can very rapidly go into retinal detachment. So very high risk for early retinal detachment. And in LMIC countries like ours, it is being diagnosed in larger preterm infants also, where oxygen use is so much rampant. So AROP is the new term which has come up in ICROP 3 classification. Then what are the consequences of ROP? So if the baby, so if there is no retinal detachment, so you catch the baby early, still there are these complications which can occur. So there can be reactivation of the disease after maybe this happens more when you give anti-VEGF to the babies. So there can be a case of persistent avascular retina. So in the long term, what you will get is field lesions, and there will be difficulties in the peripheral field vision. Then refractive errors are very common, and can get squint. And if you go into detachment part, retinal detachment part, then there can be unilateral, bilateral blindness. And there is also a late retinal detachment risk, and till up to 31 years of age. So this is a very horrible thing, which if you get retinal detachment at the age of 25 to 30 years, so this can also happen. And sometimes because of inflammatory changes, secondary angle closure glaucoma can also happen. So a brief introduction on the pathogenesis, because I have to cover everything else also. So what happens in ROP is that, so this figure very beautifully tells about the pathogenesis of ROP. So in the normal intrauterine life, what happens is there is a balanced amount of oxygen and VEGF which is there. So the vascularization of the retina progresses uninterrupted. So what happens if the baby is born between 22 to 32 weeks or 34 weeks? What happens is, so whenever this baby now coming from a hypoxic environment gets into the hyperoxic environment, so you get more of oxygen, and this more of oxygen will decrease the VEGF, normal VEGF production. And this decreased VEGF production after birth will decrease to the growth of the vessels. So in the phase 1, what happens is there is decrease in the VEGF production, and there is relative retinal hypoxia. So this happens till 30 to 32 weeks of gestation. And after that, the baby goes into phase 2. So because of the avascular retina now become hypoxic, and it now starts building its own VEGF, increased VEGF, which causes neovascularization. So what happens is now this increased VEGF will produce capillaries which are leaky. So this vascularization which now happens is neovascularization. It is not perfect. So the vessels will be fragile, tortuous, and there will be leaky capillaries. So this leads to neovascularization, which is bad for the baby. And because of exudates and other inflammatory changes, ultimately the baby can go into retinal detachment. So this, you can see that most of the ROP stage 1, 2, and 3 happens between 32 to 38 weeks of post-menstrual age. So this is the most critical part. So you can see 34 to 38 weeks, all these stages can happen, stage 1, 2, and 3. And then this retinal detachment can occur in the post-menstrual age of 42 to 46 weeks. But in very premature babies, like less than 28 weeks, the AROP can start between 32 to 34 weeks of post-menstrual age, and it can rapidly go into this stage 4 and 5. So you need to catch these babies early. That is why in very small babies, the screening is advised at around 2 weeks of just life. Uh, so that you can catch these babies early. So coming to the ROP prevention part, which is the domain of ours, because what we can do best for the babies is to prevent ROP, and I will be telling you about the various interventions which which we can do in collaboration with our obstetrician colleagues, so that the ROP incidence is less in our babies. So what are the antenatal and obstetric interventions? So you all know that prematurity is the biggest risk factor for ROP. So we need to decrease the incidence of iatrogenic prematurity. So sometimes we see that there are elective cesarean sections being done in the late preterm age group, like between 34 to 36 weeks. So these elective LSCS should stop, because the babies are still not mature, and the babies now will get more oxygen, will get more interventions, and that ultimately there are more incidents of ROP. So, what are the factors which we can do? So again, folic acid, iron, and vitamin D, healthy balanced diet will help preterm birth. Reducing obesity will prevent preterm birth. Smoking cessation will decrease PIH and less incidence of indicated preterm births. And aspirin has been advised in cases between placental dysfunction, PIH, and fetal growth restriction, and it has shown that preterm preeclampsia has reduced by 62%, and SGA incidence is also reduced. So this can ultimately lead to less ROP. पी प्रोम में एंटीबायोटिक्स दे सकते हैं, मल्टीपल प्रेगनेंसी अवॉइड करनी चाहिए, especially in IVF babies, like a single embryo transfer norm can be there in our country. Imminent preterm delivery में अगर आप कुछ कर सकते हो, so try to cover antenatal steroids and try to transfer the baby in utero to a level 3 unit, because it will improve survival and decrease morbidities. And other important intervention which we can do is delayed cord clamping. So this will improve fetal hemoglobin levels, will prevent postnatal blood transfusion, thus leading to less retinal hyperoxia and ultimately leading to less ROP. So these are the antenatal and obstetric interventions which we can do to prevent ROP. In the neonatal unit care, what we can do is, so there is a very good mnemonic which we can remember, points. So P stands for pain control, O for oxygen management, I for infection control, N for nutrition, T is temperature control, and S is supportive care. So I will be discussing in detail all these points. So in the oxygen management part, so which is the most critical factor for managing preterm infants to prevent ROP. So what is clear as of now, so there has been a huge meta-analysis on that. For less than 28 weeks, the meta-analysis recommend that we should keep target oxygen saturation between 91 to 95%. And the preterm neonate should be monitored for both hypoxia and hyperoxia. So hypoxia and hyperoxia both should be avoided, and intermittent hypoxic episodes should also be avoided. What is still not clear, targeting an intermediate oxygen range between 87 to 93%, because the majority of the trials, this range was not achieved. So we didn't know the benefits of that, because the trials which have shown that keeping the saturation low between 85 to 89% prevented ROP, but at the cost of increased mortality and increased NEC. So that is why the recommended saturation targets were between 91 to 95%. For 28 to 36 weeks babies, best oxygen target is still not there, because no RCTs are there on that, and which is we have extrapolated from the lower preterm babies gestation, 91 to 95% target for them. We are using that only, and we still not know that whether this 91 to 95% saturation target is valid for LMIC babies, because here the babies are slightly larger. So we deal most of the babies in the range between 32 to 36 weeks of gestation. So whether this target is good for these babies or not, we didn't know that. We are not knowing that. Maybe future studies will uh, show light on that. So implication for practices during resuscitation, we should follow NRP guidelines. For more than 35 weeks, resuscitate with room air. For less than 35 weeks, resuscitate with blended oxygen between 21 to 30%. Till new evidence for NICU care, keep target between 91 to 95%. Avoid excessive fluctuations of SpO2. So WHO recommends a SpO2 target of 88 to 94% with alarm set at 86 and 95%. So this is on the basis of expert opinion and various other trial results. So we keep the saturation target in our unit between 91 to 95%. So other preventive strategies, as I have told you, pain control. So avoiding pain will prevent fluctuations of SpO2. So this fluctuation will help in reducing ROP. Infection control is very important because uh, sepsis is a major risk factor for ROP, because it releases pro-inflammatory cytokines, which worsens neovascularization. Nutrition, preventing mother's own milk in the unit is very important, and starting enteral feeds early, adequate calories and proteins for good postnatal weight gain. This will increase insulin-like growth factor 1, which is a protective factor for ROP. Temperature, preventing hypothermia will reduce metabolic rate and oxygen requirement. So this will help in decreasing ROP incidence. And developmental supportive care, which includes KMC, swaddling and nesting, avoid overstimulating. So this all prevents fluctuation of SpO2, which is a major risk factor for ROP. So people have used many other drugs, not basically for ROP, but for good neurological outcome, where ROP was one of the secondary outcomes. So there was a large peanut trial in 2020, but where erythropoietin was given a very high dose, around 1,000 international unit, I think, and it showed no difference in the neurodevelopmental outcome at the age of 2 years. And similarly, caffeine was used for preventing apnea prematurity, but as a secondary outcome, uh, it showed that caffeine had some periphery potential anti-inflammatory action, and it prevents oxidative stress, and it also reduces intermittent hypoxic episodes. So CAP trial has shown that there was 37% reduction in severe stage 4 ROP. So caffeine is now being used mostly in NICUs, not especially for ROP prevention, but for preventing apnea prematurity. But it has some role in preventing ROP. Insulin-like growth factor, as I've shown that, as you know, that insulin growth factor has a protective effect in the phase 1 and vasoproliferation phase. So low IGF levels promote vasofiltration. So there was a trial on recombinant human insulin growth factors, started on day 1 of life in preemies, but it has showed no effect on severe ROP. Omega-3 fatty acid phase 1 and 2 with potential anti-inflammatory action had also shown conflicted results in small studies with small size, and a recent meta-analysis has shown no effect. And similarly, antioxidant like vitamin E and A has uh, not shown a much effect, but a recent meta-analysis with vitamin A has shown 33% reduction in any ROP, but there was no effect with vitamin A. And people have now used propranolol also. So we know that propranolol has a very good effect in uh, uh, hemangioma babies, where we had to treat hemangioma, which is causing end organ problems in the babies. So propranolol has shown very good effect in that. So it inhibits angiogenesis, and so a recent Cochrane has also concluded that prophylactic oral beta blockers may reduce progression to stage 3 ROP and decrease the need for anti-VEGF agents. But again, there were side effects in very preterm babies, less than 28 weeks. There was hypoglycemia, there was bradycardia. So still not the standard of care in most of the NICUs. So coming to the screening and follow-up part, whom to screen. So infants, so this is from Clinical Practice Guidelines 1920. So we need to screen babies less than 2000 gram or gestation age less than 34 weeks, or any preterm baby with the risk factors 34 to 36 with cardiorespiratory instability, prolonged oxygen therapy for more than 6 hours, blood transfusion history, sepsis, poor postnatal weight gain. And even if the treating physician says that this baby had a uh, uh, poor has a stormy course in NICU, so this clinician can also suggest for ROP screening. So very comprehensive guidelines for screening has come because we know that ROP is a very bad disease, so we should not have any single case of ROP leading to blindness. So that is why these higher birth weight cutoffs have been used for ROP screening. When to screen? First screening at 4 weeks of postnatal age for infants between 28 weeks of gestation or birth weight less than 12 gram. 2 to 3 weeks after delivery, again to detect AROP cases. So in that case, we should start screening early at 2 to 3 weeks after delivery. Comparison of screening guidelines. So as I had also told that names, we screened babies less than 32 weeks with birth weight less than 1500 gram. But RBSK and NNF have asked us to screen larger babies also, and that is true also because the quality of care is not at the level of AIMS. So though the quality of care is improving across the country, and we are now getting very less cases in bigger gestation babies, but again to encompass all the babies with ROP, so we should still continue to screen babies less than 34 weeks of gestation as NNF suggests. Uh, who has to screen? So you need a trained eye specialist, which has some training in ROP screening. They can screen ROP babies. How? Indirect ophthalmoscope is the best way to do that, and where? So ideally, this should be done in SNC or NICU if the baby is still admitted, or any defined area of SNCU if the baby is discharged, because during ophthalmoscopy, there can be some complications. The baby can go into apnea. So preferably in a defined area around SNCU, where SNCU or NICU, where this ROP screening can be done. How to prepare the baby prior to screening? So we usually keep baby NPO for 2 hours, and tropicamide is being used. So now this tropicamide semi is now available in the market. So initially we had to dilute to half. So now this diluted version is already available in the market. So you can do give 1 drop every 15 minutes for 3 to 4 times, and this is usually enough for dilating the baby. And topical anesthetic drops are put just before the screening. Paracaine usually 0.5%, and sucrose 25%, or dextrose 25%. Sucrose is usually not available, so that is used before the procedure to reduce the pain. And post procedure antibiotic drops, some people advise that and some people doesn't advise that. So if you have followed all the uh, aseptic measures, so no need for post procedure antibiotic eye drops. uh, but if the ophthalmologist feels, you can give that. So this is how to prepare, I think, half dilution of tropicamide, but now it is not required because the brand is now already giving tropicamide semi is available in the market. So how to follow up after first ROP evaluation? So if there are no signs of ROP, retina vascularized, so visual follow-up at 4 to 9 months of age can be done. Every 2 to 3 weeks till full vascular if it is the retina is avascular is in the zone 2 or 3 area, so every 2 to 3 weeks follow-up is advisable. And if the retina is avascular in the zone 1, then this is a dangerous area, so you know that it is very close to the macula. So frequent ROP screening every 1 to 2 weeks is required. So if ROP is present, so if the ROP is present in the stage 1, zone 1 area, so weekly follow-up or even twice weekly follow-up is required. And in zone 2, stage 1, 2, 3, according to the stage, follow-up is required. Usually it is between 1 to 2 weeks. And in zone 3, the follow-up is usually at 2 to 3 weeks of interval as deemed necessary by the ophthalmologist. So how you can improve coordination? So linking with RBSK, it can improve the coordination, and there are now studies on equipment like indirect ophthalmoscope or I think RET cams are now available. So you can improve coordination and financial support. So linking with RBSK will improve coordination and improve rehabilitation and referral services, especially in the peripheral SNCU areas where ROP screening is not available. So role of telemedicine have been studied. So there has been use of wide-angle digital field imaging. So for community, it has shown that you can use efficient resource utilization and you can overcome geographical limitation, and access to remote areas can be done and cost effective. And for the neonate, it is less painful. Education to the parents can scope for, and you can always use these images for teaching the other people also. So telemedicine in screening ROP is being done most in the south part of our country, but it is now being adopted in the northern part of India also. So treatment, so there are three modalities which are available. One is the most common used part, laser photocoagulation. The second one is anti-VEGF therapy. So, and the third one is surgery. So in the laser photocoagulation, you know that the indication as per ETROP. So any baby with zone 1, any stage ROP with plus disease, stage 3, any zone with plus disease, zone 2 stage with plus disease on aggressive ROP, then this laser photocoagulation is being done. And what it does is that it destroys the avascular part and prevent detachment. So type of laser which is used is double frequency anti-YAG laser or diode. Wavelength used is 810 nanometer. So prerequisite, you all know that take consent, ensure good pupillary dilatation, NPO 3 hours prior to the procedure, vital monitoring, radiant warmers should be there, and resuscitation equipment should be readily available because most small babies will go into apnea because of the pain. And analgesia, as of now, there is no standard guidelines for analgesia. In ROP, in AIMS, what we do is now give fentanyl at 2 mics per kg over 5 minutes, followed by 2 mics per kg per hour. But some people have checked the utility of ketamine also. But again, the standard of care in developed countries, general anesthesia, but it is not possible in our countries regarding because of the big caseload. So it will not be possible to give GA to all the babies. So most of the centers are now doing it under the provision of oral glucose or dextrose. Post laser follow-up, antibiotic steroid plus tear eye drops, TDS for 5 to 7 days. Follow-up 1 weekly to observe ROP progression or regression, and retreatment at 1 to 4 days when ROP fails to regress. So long-term follow-up for retinal status and refraction is very important in these babies. So pros for laser therapies, because it is the most studied part, considered gold standard, and well, laser retina prevents recurrence of ROP at later age also. No systemic side effects are there. Cons are because it is a very prolonged and painful procedure, requires more skill, and in zone 1 and AROP, aggressive ROP, it has shown to have poor success rate. And because of destruction of the peripheral vascular retina, so there are higher incidence of field vision difficulties and refractive errors. So these are
Dr.
the
Aman, can we
yeah.
please wind up in another minute or
Yeah,
so?
sure, ma'am. So, anti-VEGF therapy, you know that when the laser photocoagulation fails, anti-VEGF therapy is given. And even in zone 1 AROP cases also, the anti-VEGF therapy is given. So, I will discuss this slide only. So, which of this is better? So, there is always a debate that whether anti-VEGF or laser is better. So, what is that? Laser is the standard of care for type 1 ROP. So it has shown to have treatment success in 89% of the babies. And for zone 1 ROP, like and aggressive ROP, so laser has got a not a very good treatment success. It has got a treatment success of 65.9%. In that case, anti-VEGF therapy is usually given. Bevacizumab has shown to have treatment success in 91% of the babies, and Rainbow trial has shown ranibizumab 78.3%. So one important other outcome which was studied was that laser 51% of the babies will have very high myopia, but it was very less for bevacizumab and ranibizumab, 3.4% for zone 1 ROP, and ranibizumab had only 5% refractive errors. So I think for type 1 ROP, not involving zone 1, laser therapy is the standard of care. And for other zone 1 ROPs and AROP, anti-VEGF therapy should be the first line. But again, there are drawbacks of giving anti-VEGF therapy. So still guidelines say laser therapy is the best therapy. So concern is anti-VEGF drugs is that it has a risk of systemic absorption, and we don't know the long-term side effects of that, and it may suppress the normal ocular and systemic VEGF level, which may affect normal growth. So these are the main concerns which prevent us to use anti-VEGF drugs in all the babies with ROP. Benefits is that it prevents viable peripheral retina, and it is an easy procedure and not a very prolonged procedure. So there are some benefits, but there are very important concerns also. So anti-VEGF is should be used in only zone 1 aggressive ROP babies. So ROP surgeries, I will be skipping that. So how can you protect from medico-legal cases? Because you know that there has been a lot of litigation in ROP cases. So you need to create a robust system to screen eligible babies. Documentation at discharge is very important, and you need to write the date and day and the room where the baby has to arrive for the follow-up, because documentation is very important and it has to be explained in patient's own language. And a license with ophthalmologist for screening and treatment is very important. So whenever you go out of your training and start your own NICU, so you had to license with the ophthalmologists which are trained for ROP screening, and you should know that primary prevention is the best. So this will help us. So primary prevention, how can you prevent? Increase ANS coverage, and secondary prevention can be between by training district ophthalmologist in indirect ophthalmoscopy. So many states have started training of district ophthalmologists in indirect ophthalmoscopy, and tertiary prevention is training and nurturing ophthalmologists in laser and ROP laser and surgery. So these are
I'm afraid we are running out of time, Dr. Aman. I think,
thanks, ma'am.
yeah, thank you.
I
Yeah,
have concluded my
yeah,
talk.
conclude.
Thank you. Thank you.
So thanks a lot, Dr. Aman. I think you summarized a lot of important aspects, starting from, the pathogenesis, the newer staging of ROP, as well as important aspects of,